Hello, can you hear me? Okay, awesome. So my name is Victor. I'm a senior manager products and services at EHealth Africa. So EHealth Africa is part of the EHA group. There's a for-profit and there's a not-for-profit. So the for-profit is EHA Clinics, and it's a primary healthcare organization in Nigeria, which is in West Africa, for those of us that know that part of the world very well. So I'm here with my colleagues, Abdulhamid is the Deputy Director of Global Health Informatics, and our product owner of our in-house EMR, Ogochukwu, and our CEO, Adam, who is one of the biggest proponents of openEHR in West Africa, in Nigeria. Unfortunately, Adam Thompson, he couldn't be here, but he sends his regards. So I would go ahead and talk about our story, how we started using openEHR, where we are, our challenges, and all of that. And hopefully you get to see how openEHR is creating some light in a remote part of the world that some of you might not be so familiar with. EHA Clinics is a leading primary healthcare provider in Nigeria. We're the only JCI and ISO accredited ambulatory care provider in Nigeria, and I think West Africa. Currently, EHA Clinics, we have close to 50,000 patients spread across 7 clinics. And then also we have a REACH program. So the REACH program, the REACH initiative by EHA Clinics is an initiative where high-quality healthcare is brought to very low resource settings. I mean, of course, everybody knows where that part of the world is a third world country, and then there's lots of areas where there's low income, low resource, low connectivity, and those types of things. And so, of course, we had to adapt our approach and to come up with a way where we could bring healthcare to the community and provide it, at the same type of quality you expect in our brick and mortar, facilities. I'll talk a bit more about that. And so, of course, we had our challenges. EHA Clinics was established 2018, and of course, we, just like any other healthcare organization that wants to use an EMR, digitize your process and those kinds of things, we experienced those same challenges. And one of the challenges was, our operations were different. I just talked about how, we have our ambulatory care, we have our primary health care, our brick and mortar clinics. There are about 7 of them in Nigeria. But we also have, lots of populations that we want to deal with, that we want to provide healthcare to, provide that same quality, but they are in very low resource settings. So how do we meet these people? So that was another unique challenge. Even in the REACH initiative, which I talked about, there are also variations. We have variations. For example, in certain communities, we have what we call microclinics, where people can come, very low income earners can come in to get care. And then we also have community health extension workers sometimes that go to the community, go to homes and administer health care. And aside from that, we also have a few other channels like home care. So we have home care visits, and then we have telehealth. So we needed a system that could take advantage of all of this and provide healthcare across all these different approaches. So it wasn't just a simple case of just pick an off-the-shelf EMR, but maybe it works only when you are in the clinic, or pick an off-the-shelf EMR, but it only works when there's connectivity and all those kinds of things. So we wanted something that would fit our entire operation. So that was one challenge. We had looked at out-of-the-box solutions, and as everybody knows sitting in this room, they can be very expensive, and then, of course, in terms of customization, because, from practice to practice, from country to country, there are always variations. And so we wanted something that could fit our own particular workflow, our own particular way of doing things. And so these were some of the challenges that, we met. And then, most importantly, that use standardized data sets. We all know that at some point, if you are a health organization or a health facility, you're not, you don't want to get stuck with one EMR for the entire life cycle, 50, 60 years of your existence. At some point, maybe there's better technology, better tooling. You want to move your EMR to another system. And then what happens? If the underlying data sets, underlying models are, divergent, then that becomes a problem. So we wanted to deal with that particular problem at source. And so There were also other things. We wanted to also to be able to use low-code tools. And like I said, the flexibility to tailor our workflows. So all of this led us down the path of standardization and tooling. And for the standardization part, the clinical modeling, the data sets, our research led us to openEHR. And it kind of checked all the boxes for us. And then, we started down that path. But that wasn't enough. We also needed a platform because we didn't want to do things from scratch. We didn't want to reinvent the wheel. And we wanted to, have an integrated system where we can, gain all sorts of efficiencies, build out our workflows very quickly, collaborate with our clinicians, our doctors and nurses, and just knock out things as quickly as possible. And that's why, we settled on the Better platform. So we've been working with them for the past couple of years, and it's been an excellent partnership, I would say. And so putting these two together led us to build EHA Care. EHA Care is our in-house built electronic medical record system. It's built on openEHR and is supported by the Better tooling. And so, of course, there's a suite of tools, around the ecosystem, a booking application, ambulatory care, and a quality assurance application. So for a lot of people, the ambulatory application will probably be what you call your EMR. But for us, because of the uniqueness, as I just explained, of the different ways we administer healthcare, we needed a suite of tools to be able to deal with each particular concern. So that's why it's a suite. I'll talk a little bit more about that in the application. So this is just a little bit of, an architecture of how, what this looks like. A lot of this is, from the Better platform. You can see the openEHR server there, the demographic server. So if you've used the Better tooling, some of this might be familiar. But some of this too is unique to us. You can see we have Oju there, is our in-house ERP, because we also consider every patient to also be a customer, things like sales, purchases, and all those other things, memberships, taxes, and things. So that is managed in our ERP. And then we have HealthMate there. I just want to highlight those two. So HealthMate is our mobile application that we built for patients. So our patients, all of them they use this tool, and it's connected to our openEHR server. So with that mobile app, you can view your medical records, your consultations, prescriptions, lab tests, and those kinds of things. Book appointments and do all sorts of things. But of course, it's connected to our openEHR server, and then it pulls the records. So you are able to access that as a patient. So healthcare in your pocket. So how did we do it? We started with a small dedicated team of 8. And it's not just 8, developers. There was our product owner, there was quality assurance, and then I think about 4 developers working on that. And we developed 80 clinical use cases within 12 months. So things like vital signs, the forms, anthropometry, consultations, and all of that. We worked on 80 different use cases within a period of 12 months. And then we utilized extensively. So our approach, because of interoperability, was to use as much as possible, reuse existing archetypes and not go and create new archetypes. And so we reused a lot. You can see that we reused about 90% of the existing archetypes, and it was just 10% that we came up with. And so some of the archetypes that we created were for fall risk assessment, GAD-2 score, oral examination, Morse fall risk, T-chart, dental assessment. So this is just like a summary of some of there's a lot more than this, but this is a few that we just like to highlight. So I'll talk a little bit more about some of these, in the next slides. And so, like I mentioned in the previous slide, the GAD-2 assessment, it's a mental health assessment. So generalized anxiety disorder. It's just 2 questions, and then it's a total score of 6 points. And then, but of course, the cutoff is 3 points. And, if the assessment is done and, you have a score more than 3 points, then there's a GAD-9, or we like to call it PHQ-9. So a set of 9 questions that diagnose, clinical depression for our clinicians. So this is an example of one that we built. It's in our AMR, and then also the fall risk assessment. So this is another one that we built. This was custom that we did. And also the dental assessment. So this was also an example of, a custom archetype that we had to build because of our own peculiar, circumstances. So, aside from that too, like I said, we wanted an approach where we'll be able to work with our clinicians. EHA Clinics is a primary healthcare organization, and so we had, doctors, nurses, and all of them, and then we also have like a quality unit. So we wanted a way to also incorporate our own, philosophies into the process of building out our EMR. And so we adopted lean methodologies, where the entire focus is on the patient, eliminating waste and eliminating waste times. So we took advantages of, lean methodology to implement some of these. And so that meant a couple of things. Some of it meant that we had to streamline our forms. We had to streamline data entry. We had to, create dashboards where we could track wait times across the clinic, various parts, the various different operations in the clinic to track the wait times, and then to analyze this later and, do all sorts of optimization to make sure that, we eliminate waste. And so what has been the impact so far of adopting openEHR? For us, it's been nothing short of revolutionary. So both openEHR and the Better platform has been like a godsend for us. So we've improved record accuracy by 80%. Prior to adopting the openEHR standard and building tooling around Better platform, we had a system that was built on our ERP. So our ERP, if you're familiar with ERPs, is mostly for things like accounting, payroll, and those kinds of stuff. But because we wanted everything centralized, we built like an extension on the ERP for managing patient records. And, that was suboptimal. And then we had issues of, documentation errors, inconsistencies, and things. But since we, moved to openEHR and our current tooling, we've reduced a lot of that by 80%. Record completeness has improved by 50%. And very importantly, medication errors have dropped to less than 2%, which is really important for us. And then, of course, the one I like, because I'm a tech guy, is development time. We spend 70% less time developing new features and new workflows, which is really important, for us to scale quickly. And so, that's like the bulk of the presentation, but I'll just talk a little bit about our suite, what it looks like for those that are interested. So there's a core ambulatory care application that, has what you would imagine, prescriptions for managing lab tests, antenatal care, vaccinations, and things. There's a patient dashboard. So this allows clinicians to see where exactly they are in the clinic and how long they've spent, waiting times and all of that. So this feeds into a BI platform where we can analyze exactly on a day-to-day basis where patients are and then where we are actually spending time, where there are bottlenecks and all of that. So this is a dashboard. You walk into any of our clinics, you see this. And then we have a quality application. So the quality application is something we built in-house, still on the same platform. And for this, we used custom archetypes. So basically, this enables us and our quality team analyze records for all sorts of things: prescription audits, antimicrobial audits, record completion, those kinds of audits. So this is how this looks like. And there's a appointment booking application, which is just your standard appointment booking, and that. So for us, this is what it looks like going forward, some of the things that we are, working on. One of that is building a digital health sandbox for Nigeria. So what we are trying to do is to create a reference digital health sandbox so that digital health companies can adopt, can test out and try out an openEHR-based EMR solution and, for free, and then drive that, adoption across Nigeria. So that's one of the things we're working on. I didn't list that here. And then the other one, too, is trying to pitch to the Ministry of Health in Nigeria, trying to pitch a system for managing health records. That is a national health registry built on openEHR. So we are consulting with stakeholders, the Ministry of Health and stakeholders within the digital health and health sector in Nigeria to, have this done. hopefully, maybe by next year, we'll come and talk about, the successes and how openEHR is used to manage maybe 70, 80, 90% of all health records in Nigeria. So that is our goal. And then, personally, as an organization, I mentioned about how in some of the places where we operate, we have connectivity challenges, in fact, even access challenges in terms of roads, but we need to meet with people and administer care. So one of the things we're looking to do is to build a mobile app, which is currently being built with the Google openEHR stack. So Google openEHR stack offers us, capabilities to quickly build offline capable mobile apps to manage patient records. And then, of course, clinical decision support. So we're also looking at that with GDL2. We're hoping that we'll make the necessary connections here to bring that to fruition. And also working with AI. So our first version of our decision support will be based on using retrieval augmented generation with our guidelines, which are based on the British Medical Journal, to provide some sort of clinical decision support, right? So it will provide inference, and it will help, our health workers, especially our community health extension workers that are not as trained as our doctors and nurses, to be able to provide, guidance, to provide healthcare, to provide some sort of inference to enable them, carry out their work. And then, of course, to build, a pharma app for managing pharmacies, prescriptions, and things. So this is what it looks like in the future. And in conclusion, openEHR has provided a standard, based model that allows us to ensure data consistency. It has brought all sorts of efficiencies to our process. It has reduced, errors. It has helped us move very quickly, very fast. And of course, in the kind of context where we operate, scaling very quickly, and then being able to manage different types of things, whether it's a cancer screening, whether it's an optical screening, whether it's a mental health screening, being able to move very fast to create the tools, to create the forms, to collect this data, and to do it in a secure, scalable, and quality way is really important. And openEHR has provided us that, capability. So, thank you. This brings me to the end of my presentation.
Thank you, Victor. Do we have any questions?
Thank you. I actually work for Better, but this is not a leading question. Victor, that's great. Most IT teams, particularly in the UK, are there to support existing systems and then deal with integration problems. What was the feeling when the business came to you and your teams and said, we're not going to do that, we want you to build something for us from scratch? Was that a big leap for you? Did you have the skills in-house? Because that's a challenge that I definitely face in the UK.
So thank you. I mean, it was a great relief to start with, but I think there were a couple of conditions that lined up properly for us. So the first was that our CEO is, he was a programmer, he was into IT, and so he's very, very, technology, savvy and tech-driven. He's an early technology adopter, so he was the one that drove a lot of these conversations. And then it also helped us that, we understood very quickly that the system that we had was not standards-based in any way, and there was a need for us to move to something robust and secure and, scalable and all of that. So for us, it was smooth. And then we also had an in-house tech team, not the biggest one, but it was skilled, it was dedicated, and so these conditions just lined up and we're able to execute and come up with something in a short time.
Any other questions? Okay.
Hi, Victor. Very, very great presentation. So my question is around the adoption of your solution to, well, I guess your healthcare users, the healthcare providers and everything. Because having that sort of change in whether it's software or way of working and everything, I'm sure, were there any challenges that might have come up?
Yeah, absolutely. You'd imagine, migrating legacy data was a huge challenge. Switching to a new system was a huge challenge, and all of that. So yes, those were the challenges, but we're able to deal with it in two ways. So for the first one, for the legacy data, we had an in-house team that was very experienced and we had done a couple of migrations before, maybe not from EMR to EMR, maybe from ERP to other systems. So we had some knowledge on how to manage that. We had some skills in the tooling and all of that, so we're able to manage. And then in terms of the people, one of the things we did was it was a collaborative effort. So it was not just the tech team that sat down to come up with this is how this is going to work. It was collaborative. We had doctors, we had nurses, we had clinicians all in the room collaborating to come up with something that would work for us. So, you know, having that collaborative effort, we're able to get their buy-in, and I think that broke down a bunch of barriers and enabled us to, you know, achieve what we wanted to achieve.
Thank you.
Okay, thank you. One short one.
Well, thank you for your presentation. I have a question about the governance of archetypes. You told that you are almost 90% from the CKM could get, so 10% not. So the question is, what did you do did you bring your 10% from your archetype to the CKM international? If yes, what are your experience with that? If no, why you didn't do it?
Okay, thank you. Challenging question. So for our 10%, we have not brought it into the international yet, and you know we are working on that process. So for us, I would imagine that you know a lot of that was because of you know a tight timeline, you know tight budget. So we're just focused on doing something that works for us, you know, and then coming up with something that works, and then afterwards we would you know start the process of pushing that to the international. So that would be it. As much as possible, we want it interoperable. We don't want to do something that is just custom that works for only us.
Oh, sorry. There are a lot of projects all over the world where we invent new archetypes. So we should have some mechanism where we can see where everybody is busy with. So you have 10%. Maybe we are doing exactly the same, and we are throwing a lot of effort away. So, but okay.
Absolutely, I agree. And just like I said, it was, you know, not submitting. It was mostly due to, you know, some of the exigencies of our situation. But, you know, the plan is to send that up for review and to submit it to the international, not to do something just custom.
Okay, I think we can move to the next session. We do have another minute. Is there any additional one short question?
I was just wondering how straightforward the secondary data part was once you had your EHR in place, so the dashboard and the audit extracts. Was that all done with just the core software platform, or did you need to link up to something else?
Ah, okay. Sorry, I didn't quite get the question. Maybe she could explain again.
So when you produced your dashboard, was that done, and your audit extracts, was that done using just the Better platform, or did you need to integrate with something else to make that work? And was it straightforward?
So of course we had to build an application. So the EHA Care is it's a web application. So this is separate from, you know, the platform itself. For, you know, the forms and collecting the data and all of that, we had to do that to collect the data. And then also we have other systems that we communicate to. So for example, like the dashboard you mentioned, for analyzing the wait times, some of that data is piped to a BI application, I think like Tableau, for analysis. So it's kind of interconnected, integrated with different systems. It's not just one system.
Thank you, Victor. Let's give him another round of applause, please.